I'm Josie Ford. I'm a first year medical student at the University of Connecticut and also a member of the Jain Lab research team at Massachusetts General Hospital Cancer Center. We found it really important to study this combination in a real world setting. Um, all T-cell lymphoma physicians and providers know that there's a critical unmet need to address the relatively short overall survival and progression-free survival periods in patients with peripheral T-cell lymphoma and cutaneous T-cell lymphoma that are relapsed refractory. And previous studies in this space have indicated that Duvelisib, which we know is a PI3K gamma and delta dual inhibitor, in combination with Romidepsin, a histone deacetylase inhibitor, can provide benefit for these relapsed refractory PTCL and CTCL patients. The PRIMO phase 2 trial by Dr. Mehta Shah and collaborators found that single agent Duvelisib had an overall response rate of 40% and complete response rate of 33%. And then the subsequent phase 1b/2a trial published in Nature Med demonstrated the overall response rate of 55% and complete response rate of 34%. They hypothesized that the addition of Romidepsin to Duvelisib in that trial abrogated some of the toxicity from the Duvelisib itself, and they saw a transaminitis rate of 14% in that study. So what we did is we ran a multi-center retrospective and prospective observational study with our collaborators at Dana-Farber and enrolled 36 patients comprising 38 lines of Duvelisib Romidepsin combination therapy that were outside of a clinical trial from January 2016 to November 2024. And we evaluated these patients from their medical record for primary endpoints in efficacy and safety, which I'm happy to elaborate on. And we essentially found that Duvelisib Romidepsin combination, in the real world setting outside of a trial, it confirmed the efficacy, tolerability, and safety for these patients. And it does offer a novel strategy to bridge eligible patients with relapsed refractory P and CTCL to allogeneic stem cell transplantation, which we know can increase overall survival in these patients. And I'll go a little further because we obviously, as I've done, we must highlight the work done by Dr. Horowitz and colleagues in the phase 1b/2a trial and Dr. Mehta Shah and colleagues in the phase 2 PRIMO-DUV single agent trial. We feel as though this paper really meaningfully complements the data in the field and builds upon these studies by giving a more comprehensive view of how Duv-Romi is used in clinical practice, including the variations in clinical setting, prescribing patterns, patient adherence, and patient characteristics and adverse event or AE management. There's 5 ways in which our data builds upon the generalized understanding of Duvelisib Romidepsin, and I'd like to highlight those here. So one being sort of the inclusion and exclusion criteria that we applied. So unlike the controlled trials that have stringent eligibility requirements, our cohort included patients with more heterogeneous and higher risk profiles. We enrolled patients with, for example, a lower absolute neutrophil count and platelet counts at treatment start. One patient had prior toxicity to Romidepsin and was able to be enrolled. And there were no mandated washout periods in our study, making our findings more generalizable to everyday practice and the higher risk patients that we do see off trial. Additionally, we provided detailed insights in this study as to the rates of adverse events, including time to event, the severity, management strategies such as dose delays, dose changes, and in 4 cases, treatment discontinuation, which other studies didn't fully address to our knowledge. We also identify practical considerations like latent TB reactivation, and we propose proactive monitoring, especially for patients who are from TB endemic regions. And this offers clinicians practical, actionable guidance in managing this heavily pretreated population, as we understand. Additionally, we did report outcomes following Duvelisib failure in the patients that were unfortunately found to have progressive disease on the combination. But this provides valuable information for clinicians in selecting the next best course of treatment for this rare patient population. Next, we were able to observe response rates that were robust. So despite dose modifications and interruptions, especially in cycle 3 and onwards in our real world cohort, our data confirmed high response rates, supporting the regimen's effectiveness in patients that are often excluded from trials, including older adults and folks with comorbidities. Additionally, a quite novel finding that we propose from our data is that an early response assessment after 2 cycles might predict overall outcomes, which to our knowledge is a novel finding. So to elaborate on that, none of our patients who experienced partial response after cycle 2 went on to achieve a complete response despite the continuation of therapy. In fact, all the patients that had a partial response displayed progression of their lymphoma within 6 weeks time, which led to them receiving alternative strategies. So based on this small multi-center cohort with a median time to response of 1.9 months, a complete response after cycle 2 might serve as a surrogate of a meaningful response to this combination. Again, our study has limitations, but this was a novel finding out of our research and our cohort. And then finally, an important differential response that we want to highlight that's been shown in other studies, and again here in this real world cohort, is the aggregate response between 2 subtypes of peripheral T-cell lymphoma patients, the nodal T follicular helper cell, which I'll call TFH, and the non-nodal TFH subtypes. So in our cohort, we saw a significantly higher overall response rate in the NTFH subtype. Given that most of the baseline clinical and demographic characteristics, including prognostic indicators like PIT and IPI, were equally dispersed among the 2 subtype groups, I will note that PERT was a little bit lower in our nodal TFH subtype in our cohort. But given that most of them were evenly dispersed, our results suggest that these variables are unlikely to explain the differential response that we observed, and that underlying biological heterogeneity between the subtypes is actually influencing the treatment efficacy we hypothesize. Though of course our sample size limits definitive conclusions in that area. It was exciting for us to observe. So those are the main takeaways and how our study builds upon the existing work and understanding that we have in this space. The main adverse event that's been heavily discussed in Duvelisib Romidepsin is transaminitis. The grade 1B2A clinical trial had a rate of AST and ALT transaminitis of 14%. We observed a rate of 17% in both AST and ALT transaminitis, which we measured separately. So though this is slightly higher than in the clinical trial, it overall led to treatment discontinuation only in 1 patient, and that patient had actually gone on to experience grade 4 colitis, which ultimately led to discontinuation of both components of the combination therapy. So you have to keep that in mind. And it suggests that appropriate management with dose interruptions, reduction, and use of short-term steroids and growth factor support could enable continued use of the combination. More broadly speaking, zooming out from the transaminitis, overall, hematologic toxicities were the most prevalent adverse events, and neutropenia and leukocytosis occurred early in the treatment course. And then gastrointestinal, so that's including the transaminitis, and infectious complications were less frequent, but they were, of course, clinically relevant. As far as infections, we had 38% of patients experience infectious complications, most commonly CMV viremia without organ involvement. We had no cases of disseminated organ involvement. And we did see tuberculosis reactivation in one patient from an endemic area and two COVID-19 infections, among a few others. We do think that the detailed reporting of adverse events in our real world data set will help clinicians to critically think about and manage adverse events in their patients.